My name is Chris Kumar, and I'm a general cardiology fellow at the Knight Cardiovascular Institute at Oregon Health and Science University. My talk is entitled Single Access for Mechanical Circulatory Support and Left Main Bifurcation Percutaneous Coronary Intervention in Acute Myocardial Infarction with Cardiogenic Shock. All authors have nothing to disclose in relation to this presentation. Our case begins with an 82-year-old man with no past medical history who presented to the ED with severe chest pain in October of 2019. His physical examination revealed an SBP in the 80s, heart rate in the 120s, and JBP to his earlobes. He was lethargic and had a 2 out of 6 whole systolic murmur at the apex and cool extremities. Prior to angiography, his ECG revealed no ST segment elevations, an echocardiogram that showed an LVEF of 25% with apical, septal, and anterior akinesis, and a troponin that was elevated to 20.6 nanograms per milliliter. Prior to transfer from an outside hospital, angiography was performed that revealed severe multivessel CAD. There were serial high-grade lesions from the left main into the LAD and subtotal occlusion of the mid-LAD with TIMI-1 flow. There was severe ostial and proximal left circumflex disease, a CTO of the distal left circumflex, and CTO of the proximal RCA. The PDA and PL branches were supplied via mature septal and epicardial collaterals from the left circumflex. The left ventricular end diastolic pressure was noted to be severely elevated to 36 millimeters of mercury. Upon transfer, the intra-aortic balloon pump was exchanged for an Impella CP. The 14 French 13 centimeter Impella sheath was placed, and the Impella CP was then advanced into the left ventricle. Using single-access micropuncture technique, a 7 French 25 centimeter Terumo pinnacle sheath was deployed, such that a 7 French XB 3.5 guide catheter could be advanced to perform PCI. Initial angiography after Impella placement revealed a large caliber left main with 95% proximal stenosis, an LAD that had 90% proximal stenosis and 50% mid stenosis and 100% distal stenosis. The left circumflex was large in caliber with severe tortuosity and 90% proximal and mid stenosis. The RCA was not injected as it was known to be 100% stenosed proximally. We decided to pursue an Impella-assisted left main bifurcation PCI using a culotte technique. We would first focus on the proximal and mid-LAD lesions and then proceed to stent the left circumflex side branch, followed by the LAD main branch, with final kissing inflation and proximal optimization technique. The left circumflex was initially wired with a pro-water wire and the LAD with a cyan blue wire. The LAD was pre-dilated with a 2.5 by 30 millimeter NC balloon, and then subsequently with a 3.0 by 15 millimeter NC balloon from the left main to the proximal LAD. The mid-LAD was then stented with a 3.0 by 38 millimeter drug-eluting stent, and then with an overlapping 3.5 by 38 millimeter drug-eluting stent from the proximal LAD. We then turned our attention to the left circumflex, which had 90% proximal and mid stenosis. After pre-dilating, we placed a 3.5 by 22 millimeter onyx drug-eluting stent, narrowing the ostium of the left main and continuing into the proximal circumflex. We then post-dilated the stent with a balloon. We then recrossed into the LAD and placed a 3.5 by 15 millimeter onyx drug-eluting stent, again narrowing the ostium of the left main and continuing to overlap with the proximal LAD stent placed previously. We then rewired the circumflex with a new whisper wire. We completed 2 kissing balloon inflations with 3.5 by 15 NC balloons at 12 and then 18 atmospheres. Completion of angiography showed excellent angiographic result. There was residual disease noted in the distal circumflex and obtuse marginals. Color was more robustly filling the right coronary artery, which was known to be chronically occluded. This slide demonstrates pre- and post-angiography following PCI using single access for mechanical circulatory support and left main bifurcation PCI in acute myocardial infarction with cardiogenic shock. Following completion of angiography, a right heart catheterization was performed, which revealed a pulmonary capillary wedge pressure of 21 millimeters of mercury, with the initial LVEDP measured at 36 millimeters of mercury prior to PCI and Impella placement. The Impella was subsequently weaned and removed along with the remainder of the equipment for the case. We deployed 2 per-closed sutures at the Impella sheath access site. The patient was then transferred back to the CVICU for further care and monitoring in a hemodynamically stable condition. Conclusions and learning points. The IABP was exchanged for Impella CP prior to single access technique for left main bifurcation PCI. Single access technique can decrease risk for complications from vascular access in clinically unstable patients. Multivessel PCI and left main bifurcation is feasible in acute MI with cardiogenic shock via an Impella sheath with concurrent hemodynamic support of the percutaneous left ventricular assist device. Operators can be better equipped to treat and revascularize patients in cardiogenic shock due to coronary artery disease, as well as revascularize complex lesions using this method. Thank you to my mentors, Dr. Vogt, Dr. Gwala, Dr. Zar, Dr. Sigaroa, and Dr. Devanji, and thank you all for following along this case.